for this bit, but, and definitely for the Q&A, if people could turn their cameras on, that would be great, because otherwise it feels like we're into a blank room. If you could all mute, and someone isn't muted, because I can hear some background noise. So Amy, if you can mute whoever is not muted. And yeah, please just raise your hand or put things in the chat. And I think we're probably ready to go. So
thank you, Ewan, and thank you, Amy, for asking me to come and talk to you all this afternoon. I think these communities of practice could be quite useful going forward, especially as they grow and for collaborations. So I'm just going to talk to you about some of the stuff that we've got going on in Wales, what we've been using the SAIL data bank for. So I'm Becky, I'm senior lecturer in Swansea. My main research interest since my PhD has been in retinopathy screening. And I've done a lot of work around that. I can't see you guys, so while I've got my slides on, but just so you know. There we go. So I'm just going to quickly cover the SAIL data bank a little bit, just in case there's people on the call who are unfamiliar with it. I'll talk to you about the data sets that we've linked for diabetes, a little bit about a few of our research projects that I wanted to highlight, some of the issues we've had with data, again, just a couple of things that we've found and I'll highlight, and then where we're moving on with our AI projects. So the data bank, it's a total population data bank resource covering health and non-healthcare related data. It is mainly focused on the Welsh population, but you are able to upload data sources from elsewhere. And so there are a few pockets of different things, different bits of information that you can access, but these are not sort of regularly updated. We've got, for most of the data that comes in, they are updated monthly or quarterly. They're automatically fed into the data bank. For some, it's an annual feed in. They have different sources from NHS, government, local authorities, different national organisations. They focus on data for research, and it's for public benefit, obviously. Researchers can only access the data that they need and for how long that they need it. So during the whole process, which I'll explain in a little bit, you have to say what data you want, why you want to use it, what the benefits will be, and how long you need to access it for. And the important point is that no data leaves the SAIL gateway, the SAIL environment. So individual level data remains in the environment. You do all of your work in there, and then any aggregate data, so your tables and figures and things that you need to export for report writing, paper writing, that sort of thing, you request permission to get that out of the gateway. So the data bank works by the supplier. We ask them to split their data into two files. So all of the identifiable demographic data goes into one file, and then all of the clinical data goes into a second file. Both files will have a sort of common linking ID between them. The clinical data goes straight into SAIL to be loaded, and then the first file with all the personal data goes into our health digital health and care Wales, and they anonymize the data for us. So they apply an ALF code, which is unique to every person in Wales. And so it doesn't matter which data source comes in, if that person is within that data source, they would get the same unique ALF number. And then that's loaded into SAIL, and it is stitched back together based on that common ID that's in both of the fields. And then when you as the user or researcher has access to the data, all you'll see is the ALF number and your clinical data. You won't see the unique ID. So it is anonymized data. It's anonymized a few times, but other people are better to give talks about that. Here's an example of some of the data sources that we hold in SAIL, but there are absolutely loads of different data sources. So I've just picked out some of the examples that are well known about. So we've got the primary care data, so GP data, emergency admissions, inpatients, outpatient clinics, although that can be a little bit patchy because that's more patient letters, and it's difficult to anonymize patient letters. So I think there are some natural language processing projects ongoing to try and work on some of that, but it's a little bit patchy. We've got some screening data in there. So we've got the diabetic eye screening for Wales. So it's one national screening programme that feeds all of their data in for Wales. But they've also got, the cancer surveillance programmes feeding data in as well. We've got lab tests, births and deaths from ONS. We've got COVID. So SAIL was really influential during the COVID pandemic, providing Welsh Government with all their data and their analysis. And then we've got dispensing data as well from pharmacies. So some of the non-health related data sets would be education, housing, social care, and employment. But again, it's just a snapshot of what we've got, what we can use. The SAIL access. So as I said, all data sets are accessed via the SAIL gateway. So when you become a user, when you're approved, you will be given a login, your login details, and you'll log into the gateway, which is a Windows-based desktop where you do all of your analysis. So all your statistical software is available in there. You can add licenses, you can upload different software as well, depending on what you need if it's not already available. There's a two-step process for data access. The first step is the scoping review. So you meet with somebody from the SAIL team and they have a chat with you to scope out your project. And they want to know sort of how many people would need to access the data, what data sources you need, but also what support you might need from the SAIL team, what support you've already got within your team that SAIL might not need to provide for you. And then in the end, it comes out with a sort of a cost for the project. You can then use those costings to put into your grant applications. And once your grant is approved, because we know it's all that simple and quick, and we are all approved all the time, we go forward for our IGRP review, where you come back to SAIL, you fill out the paperwork, and you tell us more about the project, more details. So you say what data sources you want, why you want to use them, how long you need access to them, or for how long your project is likely to take. That goes to the Information Governance Review Panel, which is what IGRP stands for. And that is made up of people who have provided data sets into SAIL. So it would be Welsh Government, NHS organisations, local government, but it also has around about 30%, I think it is, PPI members of that group who will also review your applications. So the IGRP is generally written in a lay language that everybody on that panel can understand, whether or not they know your area of interest. The review roughly takes about 12 weeks. There can be some back and forth where they can come back with some feedback, or they can ask you some questions or give you some comments and you can go back to them. But the main thing is this 12-week process. There is no separate ethical approval required for access to SAIL data, which is really great and takes away one of our major headaches in research, I think. So some of the data sets we've accessed in Swansea or we've linked for diabetes research would be the primary care database, which is the general practice database. That's the main one that we would use. That generally has read codes. And then we've got the diabetic eye screening database, because not all of the screening data would go into primary care data, and so we need to back it up with the screening database if you're looking at retinopathy outcomes. We've linked with hospital admissions, so looking at number of people, why they're admitted to hospital with diabetes, etc., and our laboratory data as well. There's also been some work with the dispensing data. There's a couple of other teams. So one based in Cardiff, Rob French, who's linked successfully health data with education data and has looked at educational outcomes for children with type 1 diabetes. And then Lowry Allen has looked at maternal outcomes for people with for mothers with type 1 diabetes, and especially looking at teens and young mums as well, looking at their outcomes. They would be great people to add into the community of practice and maybe invite them to talk at some point. So the main projects we've looked at in Swansea, we've been interested mainly in screening intervals. We've looked at the uptake of screening and how that varies across Wales and with, between different age groups, different ethnicities, social deprivation, those sorts of things. And then we've started moving towards using retinal images for detection and prediction of systemic disease. So for screening intervals, we took data for people with type 2 diabetes. So our inclusion was that they had to have had at least 2 screening intervals without any diabetic retinopathy present within those 2 screening intervals. So they definitely had no retinopathy. And we were looking at how quickly they developed some form of retinopathy or how quickly they developed a referable level of retinopathy. And this study was the first one to report that biennial screening would be suitable for people without diabetic retinopathy, and that it would be safe to extend the screen interval from annual to biennial because the rate of development of sight-threatening retinopathy was particularly low in this group. There might be a slight exception for those who have a longer duration of diabetes or were using insulin therapy because they had a slightly higher risk. So it depends on where the safety levels are placed. We took that forward a little bit further and we looked at the cost effectiveness of screening intervals for diabetic retinopathy. So this was for type 1 and type 2 diabetes. And so the base case analysis for that showed that extending the screening interval was cost effective for both groups. However, when we did the sensitivity analysis, we found that whilst it stayed cost effective for type 2 diabetes, for those with type 1 diabetes, if they had a longer duration of diabetes or they had higher HbA1c levels, it was no longer cost effective to have a biennial screening interval and that they should remain really on an annual screening because the risk of progression was too great. There are obviously a lot of problems with data when we're looking at all of this. Type of diabetes is problematic because there are multiple codes, especially when you're looking at GP data and then hospital data and you're working across read codes and ICD-10 codes. And these codes change as well. So they've changed over time, but also they can change for the person. So somebody might be diagnosed with type 2 diabetes first and then might be realized that they type 1 diabetes, or vice versa, or that they might have a genetic form of diabetes. And so those codes are changing, but when you're looking at data, you can't really tell why they've changed, only that they have. So it's which codes do you trust? HbA1c has changed over time. So if you're looking at legacy data, you really need to be aware of the changes in the measurement of HbA1c. We've gone from HbA1 to HbA1c. That has been a subtle change, but it has increased slightly. And then there's a change in the measurement. So we've gone from percentages to millimoles per mole. That is a much more dramatic change. So like a 10% would equal something like 86 millimoles per mole. So it's a little bit easier to pick that one out. Blood pressure is difficult to work with because it's systolic and diastolic all within one cell, and you have to work out which is which. And date of diagnosis of diabetes, meaning that duration of diabetes becomes unreliable if the date isn't recorded properly, and sometimes the date relates to registration with a GP practice rather than when they've actually been diagnosed with diabetes. So one of the things we've done to solve some of those issues, I've just focused on the type of diabetes to start off with. And we've worked out an algorithm within SAIL to assign people to type 1 diabetes, and then other codes then would be type 2 diabetes or maybe some of the genetic forms. But so for type 1 diabetes, if they've got majority codes of type 1, they've got certain restrictions as to whether or not we give them a type 1 diagnosis. And then if their majority codes were majority of the codes were not type 1, they were something else, but there was a type 1 within them. They've got a slightly more restrictive coding, which allows them to become coded as type 1 diabetes. And as you can see in this, a large amount, so we had 7,600 people with a main diagnosis of type 1 diabetes meeting our criteria, but only 168 people who had majority codes for something for other than type 1 diabetes came into our cohort. This we were then able to allow other teams to work with, and they were able to apply it. So this one was led, I think, by Rowena Bailey's team. And they were looking at the incidence of long-term complications in Wales over the time of COVID. And originally they planned for diabetes to be looked at as one group. So you can see that on the graph at the top, you can see diabetes. And then underneath that, you've got type 2 diabetes, which very much mirrors the underdiagnosis that was seen in general diabetes. But when they then were able to separate out type 1 diabetes, they found that actually, whilst there was an underdiagnosis of type 2 diabetes, we saw more diagnosis of type 1 diabetes during the pandemic. So it allowed us to look at things slightly differently and see these analyses a bit more clearly. It also allows us to look at complications slightly differently, because type 1 diabetes can have a greater risk of developing complications. We've started to move over to look at the retinal images, and this is where one of our major issues is coming from. So we work with a team from the Chinese University of Hong Kong. They had developed a automated retinal image analysis algorithm using machine learning. They used R and MATLAB to develop that, and they have patented it. And they've got one to estimate the risk of stroke, another for white matter hyperintensities, and another for coronary heart disease. We managed to get permission through ethics to move 1,600 images from the Diabetic Retinopathy Screening Service for Wales into SAIL to allow a validation of this, of the ARIA algorithm. So that was great, although it is only a small subset of the images that would be available from Diabetic Eye Screening Wales. So our next projects, we currently have several PhD students starting with us to look at how we can develop AI for the detection and prediction of other microvascular complications of diabetes. So we've got kidney disease and retinopathy. And then we've got a Diabetes UK funded grant to look at preventing peripheral neuropathy. And then another Diabetes UK funded PhD student is going to start with us sometime this year, I think, to look at how we develop communication strategies to inform our patients of their risk of all of these different complications without increasing anxiety, stress, or increasing the stigma that is associated with diabetes as well. So the retinal images is currently, we have issues with information governance. So we've been seeking permission from Public Health Wales to move all of their retinal images into SAIL that's obtained through the national programme. But so far we've been in discussions for about 5 years. And I think we might be slowly getting somewhere, but it's, I've thought that before as well. They have delayed so far. They're having issues around consent, whether or not patients are being asked to consent appropriately at the time of screening, whether or not we need separate ethics. They consider the retinal images to be biometric data, so they have issues around storage within SAIL. And their main issue is staff time. They don't have staff time to be able to take the images off the SAIL data bank, off their data bank, and move them over into SAIL. So that is one of their main issues. So my Q&A, I would like to turn it around on you guys, and instead of you asking me questions, I'd like to ask if anybody has had any good stories, how they've overcome some of these issues And yeah, if they've got any advice, I think we're making progress on some of them, but who knows? So that's just a summary of what I've been working on, some of the projects that we've got currently ongoing in Sale. And yeah, if anybody can help with some of those issues, that would be great. And that's all I've got.
That's brilliant. Thank you very much, Becky. So yes, some homework for us all to be thinking about while Fiona talks. And some nice parallels actually, as Fiona's going to talk around how we've defined type 1 and type 2 diabetes in the data. So I think we should move straight on. And Fiona, the floor is yours.
So hi everyone, I'm Fiona. I'm an early career health data scientist at the British Heart Foundation Data Science Centre, and like you said, I'm going to be talking about the diabetes algorithm that we've been developing as part of the Catalyst over the last year and a half. So I'm not going to talk about the Catalyst that was introduced at the last meeting, but just in case you forgot, one of the main aims was to evaluate how we can best define diabetes with the population-wide data that researchers have available to them. So we wanted to define a phenotype and algorithm that would then define a diabetes cohort or diabetes at population-wide level and the type of diabetes that a person has and their date of diagnosis. So before I go on to the algorithm, I'm just going to spend a few more minutes talking about that population-wide data that researchers have available to them, because this informed a lot of the algorithm development. So if you're unfamiliar, there's many different areas and parts of the British Heart Foundation Data Science Centre beyond the Diabetes Catalyst. One of our main areas is called full population data, and this is where we're working with structured data or electronic health records, data that's collated at a national scale to do cardiovascular research. We have a project there called CVD COVID UK COVID Impact that drives most of that work, and the aim of that project is to understand the relationship between COVID-19 and cardiovascular diseases. And this is that project in numbers then. So we have a consortium with over 400 members. They come from many different institutions, and we have over 120 sub-projects that run under CVD COVID UK COVID Impact. So they are all projects that have their own specific research aims and questions, but of course they will relate to COVID-19 and typically cardiovascular diseases. There are some projects whose main aims and questions do relate to diabetes, because we had a diabetes call for funding under the Catalyst. So of course they will want to define diabetes, but for many of the projects who are more concerned with CVD, they will of course want to define diabetes as well, given the close link between cardiovascular diseases and diabetes. A lot of them would want to define their cohort and then link define diabetes and have it as a risk factor in their analysis, for example. So how are the projects then defining disease? Well, they're doing it via data, a lot of data. So they have access to 3 national TREs, access to over 70 data sets. Their access to Scotland has momentarily lapsed, but they will have access to that again shortly. But 2 main things I wanted to point out here was they have access to data, and a lot of it. So, and it's population-wide data. And if you have ever worked with electronic health records or indeed population-wide data sets, you'll know just how long it takes to bring these projects together. The underlying data sets are they're large, they're very complex, they take a while to get your head around. And the second thing I wanted to point out was that they don't have yet access to diabetes-specific data sets. So they can't just define a cohort and then link to a diabetes audit, for example. They have to define diabetes, much like Becky was saying, using other data sets that they have available to them. And that's typically done using primary and secondary care. But for something like diabetes, of course, you would want to consider prescribing data as well. And that's exactly what our algorithm is doing. It's using primary and secondary care and prescribing data to define diabetes. And really what we're trying to do is accelerate research for those projects. So if a researcher or an analyst can come in and they can have diabetes already defined for them, they don't have to spend a lot of their time worrying about diabetes code lists and the algorithm, and they can move on and define other diseases of interest to them or spend more time on their analysis. And just one point another point that I thought of when Becky was speaking is the researchers, they have access to the 3 nations. And although they have the best of intentions to do their research across those 3 nations, this, what typically happens is they start in England, it's got the biggest population, and they run out of time because it is just so complicated to pull this research together, and then they don't then have time to take it into Scotland and Wales. So again, if we can define diabetes for them and other diseases for them, then maybe that would help them take their research into Scotland and Wales and be able to do a full 3-nation approach there. So that's the data. Before I talk about the algorithm, I did just also want to touch on something that Ewan mentioned, and is how this came together. So it was very much a team science approach. It wasn't just an algorithm made by Ewan or the British Heart Foundation Data Science Centre. We had working groups that ran fortnightly for a year and a half. So if you were working in CVD COVID UK COVID Impact Project and your main project aims and questions were related to diabetes, you attended these working groups, and the groups reported on how they were getting on with their research, and that was great, really informed the algorithm development. And then as we were developing the algorithm, we took sort of key stages of it to workshops where we had a lot of clinicians. I think some people that attended them are actually in the call today. And we made decisions on key parts of the code list and the algorithm development there. Okay, so the algorithm I am going to talk through via an app that we've developed. So at the Data Science Centre, we're committed to open source and reproducible data science. So that means all the code that we develop inside a secure data environment, or indeed outside, we put on GitHub. We want to be really transparent about the work that we do. But also we have a lot of members in the consortium who are not analysts, so they might not be coders or programmers. A lot of them are clinicians or epidemiologists, so they might not code, or they might code and they might just not have time to go through screeds of code and script to understand algorithms. So this is the point of the app. We want to be very transparent about the process and document the development of it, the app itself, so that if a researcher or a new project in the consortium wanted to use this, they can quickly check the app and make an informed decision as if this is the right algorithm for them or not. So I'm just going to talk through a few key parts. I'll start with development. So it took over a year to develop this algorithm. I think it can be split into 2 parts. So there's code list development and then the algorithm. I think you'd think the algorithm would take longer, but actually it's code lists, because there's just so many codes that exist for diabetes. So like I said, we were defining diabetes used in primary and secondary care. So we were considering SNOMED and ICD-10 codes, and we didn't just start from scratch. So we didn't start trawling through these sort of libraries, because there's so many code lists that already exist out there. So we kind of exhausted HDR UK phenotype library and Open Safely Open Code List library for code lists, and we asked members of the working group if they had any code lists already developed that they wanted to bring forward for consideration. And I don't know if you've ever used the phenotype library. It's a fantastic resource, but if you type in diabetes, you're returned with 159 different diabetes code lists. So the question is, which one do you use and how are they different from each other? So with that in mind, we had almost 700 SNOMED codes to look at, and about 70 ICD-10 codes to look at for consideration. And this is how we've done it. So we use this app. Each row here represents a code, and each column represents a specific code list or phenotype. We've done it for SNOMED and then ICD-10 codes. And you can very quickly see which phenotypes or which code lists include which codes and which do not. So 2 things we had to do. We had to consider which codes we would exclude and not take forward at all. And then also there was a classification task to be done. So we needed to consider what codes would be typed as type 1, type 2, other diabetes, and then not otherwise specified diabetes. We drilled a lot into the codes. We looked at code importance, code uniqueness, and I just wanted to touch on a key finding from this exercise. So we looked at this code, we discovered this code called Quality and Outcomes Framework, Quality Indicator Related Care Invitation. It's a really common code, so it's the top 3 here. So lots of people within this is the prevalence of people that have this code within the NHS England SDE. A lot of people have this code, and it was used in 4 of the 11 SNOMED code lists that we sourced. So people are using this to define someone as having diabetes. what we discovered was a lot of people were being introduced to a cohort via this code only. So what that means is they only have that code and they don't have any evidence of any other types of diabetes codes. For something like diabetes, that is quite rare. That doesn't usually happen. So what you typically see is that they have the main type 1 or type 2 code, then they also have a handful of other codes for like retinopathy screening, foot examinations, for example. But in almost 20% of a cohort was being introduced via this quality and outcomes framework code. So we drilled a little bit more into it. We found that of those individuals who had that one code only, no other diabetes code, only 14% of them had a record of insulin, and only 2% of them had any record of high HbA1c ever. So that was one of the things that we took to one of the workshops, and we made a decision that that code should be excluded from our code lists, and we will feed back to projects who have already used that code and recommend that they take it out going forward. So I'll leave code lists there, and I'll just move on to algorithm development. Again, we didn't start from scratch. There's already amazing algorithms out there. Two that we knew were gold standards were one that were called an Open Safely algorithm. It wasn't actually developed in Open Safely. It was developed in Biobank by Sophie Eastwood, but then it was taken into Open Safely and adjusted there. That's when we discovered it, and that's why we've tended to call it the Open Safely algorithm. And it was also taken further into NHS England and adjusted again there. And then the other algorithm that we considered was the Exeter diabetes algorithm. So what we did was we took those two algorithms, we took them into NHS England SDE, and we coded them up there. You can see the flowcharts and table ones there, and we used that to inform how our algorithm would come together. So basically our algorithm, this is a flowchart of it, is a combination of Exeter and Open Safely with some parts of some steps tweaked, and we've added some steps in here and there based on the sensitivity analysis that we were doing within NHS England. I'm not going to go too much detail into it, but a few key points are the step one is if you have any other diabetes codes, you're straight away classified as diabetes other based on codes only. The sort of idea there was that if somebody has went to the extent of defining you as having other type diabetes, that's what you probably have, even if you have some record of type 1s or type 2s. We have this bit that ensures that if you're more than 3 years beyond your diagnosis and you've never been on insulin yet, then you would not then be typed as diabetes type 1. This part of the algorithm then sort of deals with the codes only, so looks at how many type 1 and type 2 codes you have to allocate you between type 1 and type 2. And then you get down to these discriminators here that bring things in like HbA1c and anti-diabetic medications. You can end up being unlikely, so you can go through that whole process and you can still you might be eliminated from the cohort in the end. So that's the flowchart, and we provide a table 1 of it, so you can drill into the table 1 via diabetes type or by each step, and you can use that to validate the algorithm. You can drill into age at diagnosis if you're interested, and that's by BMI and ethnicity. And then you can also compare how it performs to the Open Safely or Exeter algorithm. So to sort of validate this algorithm as we went through, what we did was we looked at the type 1 percentage in comparison to type 2 other, so the type 1 to type 2 other ratio. The reason we've done that is because you can get that information from the National Diabetes Audit. So when we were changing steps of the algorithm, we sort of paid close attention to how that type 1 percentage changed. So under the NDA, that type 1 percentage is around 7, Exeter's around 3-4, Open Safely is about 8-9, and then ours lies somewhere in the middle. I'm not saying ours is correct, I'm saying this is expected given it is a combination of Exeter and Open Safely, that ours would be somewhere in the middle. And indeed, then you can make an informed decision as to what algorithm might be right for you and your research questions. We done lots more. We looked at reclassification. This looks really scary, but basically we reran the algorithm year on year to understand how somebody's diabetes type would change. It doesn't really change, so that's good. Even when you've got a whole extra year's worth of information, they typically 99% of the time stay the same type classification. You can look at it in a log scale if you want to scare yourself, but it's just to sort of look a bit more as to how people change year on year. And the last thing I wanted to touch about, well, you can also look at the sort of methodology and understand how we process the data, the limitations to our data. and any definitions that you used. But the last thing I wanted to touch on was how this was validated. So like I said, we kind of validated it as we went through with clinicians, people like Ewan, with Table 1, etc. But we're also really lucky to have that CVD COVID UK project, because we have 5 projects that are already using this algorithm. So that's great. They're already defining diabetes using this exact algorithm, and then they were able to feedback how they were getting on with that definition as part of their project. And really lucky, with thanks to Nick Thomas and Katie Young from Exeter, we are validating the algorithm using type 1 genetic risk scores. So we were specifically looking to try and maximise the specificity of type 1s, so trying to prevent type 2s being misclassified as type 1. This exercise is not finished yet, but we're using it to inform step 3 and step 6.1 of the algorithm. So for example, step 3 will likely be changed from 3 years from diagnosis to 1, and step 6.1 we were using recency rules to distinguish between type 2s and 1s. So we were looking at what code was the most recent, but we're now considering ratios of type 1 to type 2 to do that. So I think 2 to 1, type 1 to type 2 is the most specific, but we're also looking to run it through 1 to 2 or 0.5 to 1. And last thing is, how are we encouraging adoption of the algorithm, especially within the SDE? Well, we're encouraging it by doing all the work basically for a researcher. So it's all coded up and it's running on a workflow such that researchers don't even have to look at the code if they don't want to. They can specify their job parameters specific to their project. They can point it to our GitLab, and they can choose the version of the app of the algorithm they want to run. So we only have version 1 right now, but we're anticipating we might have a version 2 after that validation task that I just mentioned. And we are also typing it up in different languages, because we use PySpark within the NHS England SDE to sort of take advantage of distributed computing power, but most researchers prefer R. So it's in 2 languages. And kind of wrap up there, but we do have next steps. We're committed to maintaining the algorithm, the versioning, evaluating code lists and data sets, and there's projects that plan on using it in Wales and Scotland. So Becky, it'd be great to look at your algorithm in Wales and compare. And yeah, I think there's also plans to have it run in Open Safely as well. Thank you so much for listening. I'll stop there.